like the last one, the same objective. We're just going to try to improve everyone's understanding. We'll skip, everyone kind of understands how injuries happen here, the recurrent injuries or traumatic. Surgery, they dislocate the hip, they go in, there's complications. In the previous course, I just wanted to note there was 5 phases or 4 phases of rehab. In our scope, again, as we're talking about the return to sport aspect, we're considering a 3-stage athlete. So our stage in here is somewhere between 2 and 3, what we would call the mid-stage athlete. Some prerequisites we're looking for acetabular labor repair are going to be just that pain-free and normal gait pattern, strength, meaning knee extension, hip flexion, is within probably like 70% of the contralateral side. Again, the research is sort of loose here, so we're trying to apply some principles from what we know of our cousins of the ACL repair to this. The time frame again falls somewhere in the 8 to 12 week mark. I wouldn't say there's a ton of research to say, oh, you're a mid-stage athlete based on the fact that they're 8 weeks or 12 weeks. But if they meet this criteria, you can kind of try to put them in that bucket and say, okay, we could probably start to load them a little more according to some strength conditioning principles, add in some intensive, extensive biometrics, and et cetera. Some folks at this stage just want to improve strength and endurance, start to gradually work on external rotation range of motion, obviously within tolerance and not into pain, and improve some balance and proprioception. So some rehab goals here, we just want to normalize, again, the gait and running pattern as it starts to get back to that. Same kind of preparatory things we want to do as with the ACL, we're going to see with the labor repair. Labor repair might tolerate it a little less comfortable because of the hip flexor kind of repetitiveness. So if that gets angry, I think we all kind of know, let's just let it be and it'll feel fine on its own in a couple weeks. We want to make sure we have little to no pain and swelling after exercise. Again, full range of motion across the hip by the end of this phase. And then just the same, tolerating that introductory plyometric loading of 8 to 100 per session and successful completion of the return to run testing. So it's pretty straightforward as what we're all aiming to get out of this. It's just, we're trying to emphasize the fact that when you see someone, you're like, oh, they're just kind of mid-stage. Before I see them, before they're discharged, before they meet that 12-week mark, let me just try to make sure, are we within range of motion? Is strength good? And are we trying some plyometrics? Are they tolerating it well? Great, we know they can kind of head to the running. Starting off with our high motor recruitment, high threshold activity, getting good blood flow, good task demand, all that going. Building into some strength, working into muscular endurance, going into neuromuscular balance, and cool down. At the late stage, some of the things that these patients should have achieved, right, are full range of motion, strength is equal to the opposite side. They're probably biologically greater than 12 weeks, just talking about the healing time frame of the repair. And then really the goals here is to return to sport-specific drills without pain and pass the return to sport test. So what I will say is, in the context of the return to sport test and the return to run test, I had those flipped in order. For labor repair, there's not a specific like mechanical deficit I'd be looking for. I don't seem to find, at least in my minimal experience of treating labor repairs, that there's a ton of mechanical or muscular deficits that persist following that. But you just want to make sure that they're comfortable and it's tolerated well. So as long as they're performing the tests and nothing is blatantly sticking out to you and you're like, oh, that looks scary. As long as they're not complaining of a lot of pain or discomfort with it, I would say it's probably a pass. A little easier to give them a go here because structurally there's not something so fixated or changed here. Moving on, Achilles tendon repair. Same objectives here, no big changes. So a brief review. Not super common, right? 5 to 10 per 100,000, but it's common enough that we see a good amount of them. Predominantly is going to occur with recreational sports. Think about that loaded dorsiflexion demand, landing or lunging forward, right? So usually a deceleration activity. Typically occurs right 2 to 6 centimeters between the mid portion of the calcaneal insertion or proximal to the insertion. At the mid stage, a lot of these things we really probably are getting past, but there could be some things that are persisting, such as like the nerve damage and paresthesia. So when Dr. Grusky was here for the last course presentation, a big thing he meant to point out is if you're seeing at the fact that they're like 12 weeks out, 8 weeks out, and they're still complaining of a lot of pain and kind of a throbbing ache with inactivity, kind of send them back to the doctor. There's usually pretty common that there's some nerve damage associated with the repair. So just mention it to the doctor. He seems to want to know about it specifically. I can't speak for other surgeons. But in particular, that's probably the biggest thing that's prolonged lasting as we meet that kind of mid-stage. So the mid-stage, things we're looking for is that the boot is DC'd. Everyone loves that day, hallelujah, you can do something with your Achilles repair. You're not just sitting there having them kind of like do toe yoga and other things. They'll be transitioning to air cast. Again, the timeline, anywhere between 8 and 20 weeks. We all know our foot and ankle surgeons kind of be finicky when it comes to the Achilles repairs, and they're really protective or they're not. It really depends on what they feel. And this is kind of your own clinical judgment of whether you want to call someone mid-stage or not. Goals here, really just get rid of that air cast, improve strength, and return to running. So it's a really big, longer gap of rehab for these people versus the other two surgeries we talked about. But the demands and the testing really remains all the same. Some rehab goals we're looking to establish with the mid-stage. Again, is normalized gait without a heel lift, so that cup should be removed by this point. Little to no pain or swelling, something we've seen with all our diagnoses so far. Full range of motion. With even weight bearing, standing heel raise. Right. Able to perform a single leg heel raise for 3 sets of 15. That's really freaking hard. So I have not had many patients that can do that. I had some plantar fasciitis the other day and I tried to do it myself. It's pretty hard to do. The Achilles tendon rupture scale score has some really good evidence to support that. That's going to give you a good idea of how prepared they are to kind of transition back to things. So a score of a 20 to a 69 is kind of considered appropriate for them to start kind of more running demands and like sport-specific tasks. So I implore you guys, if you have any Achilles, look into it, maybe hand it out to your patient if you're like a slow day, and you're like, oh, try this out, take this Achilles tendon rupture scale, and give me an idea of where you're at, and at least it gives you some framework. You can, with a very easy Google search, you can kind of find a good amount of stuff on that. We're looking for the 1RM leg press to still be within 90%. Although it's a fair amount of loading on the Achilles, it's not a ton of strain, so it's okay at the later stages once the doctor's kind of happy with them loading. Really, if they're going down the stairs, they're probably putting more load on their Achilles than they would be doing a 1RM max test. So at least with the 1RM max test, you get a better idea of what their muscular capacity is, what they can output with the rest of their leg. Because as we all know, that entire limb atrophies. It's not just the wimpy little calf that they have forever. And then lastly, again, tolerating the plyometric introductions. As far as late stage, really we just want to make sure when they reach that late stage where we would discharge them from therapy, they transition to a strength conditioning professional. We want to normalize gait, return to jogging. They should be able to do at least 10 unilateral heel raises, right? Somewhere in the 3 to 6 month mark. It really depends on what protocol you look up. Brigham Young Hospital has 6 months. Someone else, Mass General, has 4. There's not too much research on here to suggest that there's a particular timeline. So use your clinical judgment, kind of see how they're tolerating stuff, and go from there. And then lastly, kind of normalize strength, return to unrestricted activity. The Achilles tendon rupture scale, as I remember, the score is somewhere between 25 and 100, but that seems to be a little high compared to what the previous number was. And then lastly, successful passing of a heel rise test. So if anyone's not seen a heel rise test, you're going to stand on an elevated platform that's like an inch or so high, and they're going to do single leg heel raises on a metronome, 1 second up, 1 second down. There's age-related criteria for that, depending on the sex, male or female. And then, just like with the push-up endurance test and all of that, typically like young males, like 20 to 25, tend to perform the highest. I did it the other day, and I kind of fell in the like 30 to 40-year-old category, so I have a little calf strength to work on. But you will be humbled very quickly. So if you're looking for a good test for your Achilles patients, towards the end of the rehab, it can be a great option.